Ischemic stroke, Part 1. Transient ischemic attack, or TIA. It is a brief episode of neurological dysfunction that resolves within 24 hours, caused by focal brain or retinal ischemia, without evidence of infarction, on neuroimaging. It may be an important warning for an impending stroke. Signs and symptoms. Most transient ischemic attacks resolve within 30 minutes. TIA occurs due to occlusion in the carotid territory, may present with ipsilateral, monoocular blindness, also known as amaurosis fugax, contralateral hemiparesis, numbness and weakness of one side of body, dysarthria, and rarely hemianopia, weakness of only one limb, isolated facial weakness, as evident by drooping of face. TIA due to the involvement of the vertebrobasilar artery territory may present with ataxia, dysarthria, hemianopia, diplopia, sudden falls, weakness, and numbness on one or both sides, difficulty in swallowing, vertigo, and tinnitus. Clinical findings of cerebral ischemia associated with cerebral vascular territories. A careful history and neurologic examination can often localize the region of brain dysfunction. If this region corresponds to an arterial distribution, the possible causes responsible for the syndrome can be narrowed. This is of particular importance when the patient presents with a transient ischemic attack and a normal examination. For example, if a patient develops language loss and a right homonymous hemianopia, a search for causes of left middle cerebral emboli should be performed. Stroke syndromes are divided into large vessel stroke within the anterior circulation, large vessel stroke within the posterior circulation, small vessel disease of either vascular bed. Stroke within the anterior circulation. The internal carotid artery and its branches comprise the anterior circulation of the brain. These vessels can be occluded due to intrinsic diseases like atherosclerosis or dissection, or by embolic occlusion from a proximal source, as discussed above. Occlusion of each major intracranial vessel has distinct clinical manifestations. Middle cerebral artery or MCA infarct. Signs and symptoms. Complete MCA syndromes occur most often when an embolus occludes the stem of the artery. If the entire MCA is occluded at its origin, the clinical findings are contralateral hemiplegia, hemianesthesia, homonymous hemianopia, a day or two of gaze preference to the ipsilateral side, dysarthria, facial weakness, global aphasia, anosognosia, constructional apraxia. Partial syndromes include branchial syndrome, which is hand weakness alone, frontal opercular syndrome, which includes Broca's aphasia, with or without arm weakness. If the temporal cortex is involved, the patient may have Wernicke's aphasia, jargon speech, and inability to comprehend written or spoken language. If the central, suprasylvian speech area and parieto-occipital cortex are involved, patient may have central aphasia, word deafness, anomia, jargon speech, sensory agraphia, acalcula, alexia, finger agnosia, right-left confusion, the last four comprising the Gerstmann syndrome. Anterior cerebral artery or ACA infarct. Signs and symptoms include profound abulia, in which there is a delay in verbal and motor response, or akinetic mutism, and bilateral pyramidal signs, with periparesis or quadriparesis, and urinary incontinence. Involvement of the motor leg area results in paralysis of the opposite foot. Other signs and symptoms include impairment of gait and stance, or gait apraxia, contralateral grasp reflex, sucking reflex, Jejen-Halton, or peritonic rigidity, dyspraxia, cortical sensory loss over toes, foot, and leg. Anterior choroidal artery infarct. The complete syndrome of anterior choroidal artery occlusion consists of contralateral hemiplegia, hemianesthesia, and homonymous hemianopia. To get more such high-yield medical content, don't forget to subscribe. Visidia Med. The easiest and fastest way to take advanced clinical history.